hips, the knees, the ankle, and the small joint of the feet. We are following the rule of a look, feel, and move, or inspection, palpation, and movement. بسم الله الرحمن الرحيم. أنا دكتورة هويدا منصور. I will do rheumatological examination of the hips. أتشرف اسم حضرتك؟
محمد عبد المنعم.
طب يا محمد أنا هفحص مفصل الفخذ. في أي حاجة بتوجعك؟
لا ما فيش.
تمام شكرا. Hip joint examination starts by inspection, palpation and movement. And for inspection we first inspect the gait of the walking patient. امشي في المكان كده من فضلك. We inspect the gait for rhythmicity, symmetry, and the smoothness of the gait. This is the normal gait composed of 4 phases. Starts by heel strike, loading, then toe off, and swing. If the patient has arthritis in any of the lower limb joint, hip, knee, or the ankle, he may got an antalgic gait where the patient spend a short stance phase on the diseased side and spend most of the gait cycle on the healthy side, so he will hurry off on the diseased side. Inspection and palpation and movement. After inspecting the gait of the walking patient, we will inspect the region of the hip joint. The hip joint is a deep-seated joint. It's difficult to inspect or to palpate. However, if we can do a pressure midway between the symphysis pubis and the anterior superior iliac spine here. This is the head of the femur. So we palpate for any tenderness. في أي وجع كده؟ We palpate for hotness of the hip joint, comparing with the other side. The hip joint pain in hip arthritis, it is a referred pain, will be referred to a wide area, the anterior and lateral upper 1/3 of the thigh, and the buttocks and the groin region. So we depend much on the hip joint movement in testing hip arthritis. The hip joint movement, I will start first by flexion. I will put my hand, the patient should lie flat in bed. I will put my hand behind his back. اتني رجلك خالص على بطنك. This is the hip flexion. Then while the patient still on his back, this is the adduction movement, and سيب رجلك خالص, and this is the abduction of the hip. Then I will let him lie on his side. نام على جنبك اتفضلك. This is the flexion and this is the extension of the hip. Again on your back, نام على ظهرك تاني. I will do the same movement on the other side, comparing the movement of both sides. The rotational movement of the hip is very important, and it is the earliest movement to be affected in any hip arthritis. So we will test for the hip rotation by 2 tests. The first one is called straight leg roll test. This is the internal rotation. This is the external rotation. Then the second test is with the knee flexed 90 degree and the thigh flexed 90 degree and using the leg as an indicator. And this is the external rotation and this is the internal rotation of the hip. Thank you. السلام عليكم.
السلام ورحمة الله وبركاته.
أنا دكتورة هويدا منصور، هفحص مفاصلك النهاردة إن شاء الله. في أي حاجة تعباك توجعك؟
إيديا ورجلي.
تمام، ألف سلامة عليك، ربنا يشفي إن شاء الله. On rheumatological examination of the hand and the wrist region, we start by inspection, palpation, and movement. We inspect the hands. First, we inspect the nails for nail picking or onycholysis and psoriasis. We inspect the skin for hyperpigmentation or erythema, any rash. Here there is depigmented areas and hyperpigmented skin. We inspect the skin for some skin tightness, like in scleroderma. We inspect the muscles. There is interosseous wasting here, as you see. We inspect the hypothenar and the thenar eminence, the hypothenar and the thenar eminence for muscle atrophy. This patient has disuse atrophy due to aggressive rheumatoid arthritis. Then we inspect the joints for any swelling or deformity. There is a swollen wrist joint bilaterally. This is a dorsal displacement of ulnar styloid. There is a swelling in the metacarpophalangeal joints, as you see. There is a swelling in the proximal interphalangeal joints here by inspection. Also here there is a swelling in the wrist joint, but much less than the right side. There is a swan neck deformity in the middle finger here and here, in the ring finger and in the little fingers. This is a typical swan neck deformity, hyperextension of the proximal interphalangeal joint and flexion of the distal interphalangeal joints. Look for any ulnar deviation of the fingers here. And here also there is the deformity of the thumb. There is flexion in the first metacarpophalangeal joint and hyperextension of the single interphalangeal joint of the thumb. Here also there is a swan neck deformity in the little finger of this hand. So we inspect the nails, the skin, the muscles for muscle atrophy, the joints for any joint swelling or deformities. Now we'll palpate the joints. We will start palpation for hotness, for tenderness, for the nature of the swelling. This is the 3 items of palpation. Hotness in every joint region. This is the distal interphalangeal joints, the proximal interphalangeal joints, the metacarpophalangeal joints, and the wrist joints. There is hotness in all these joint regions. This means active arthritis. After palpation for hotness, we will start palpation for any tenderness. Hotness, tenderness, or swelling, any one of these indicates arthritis or synovitis. We will palpate the wrist joint, asking the patient if there is any tenderness. في أي وجع كده? There is tenderness in the wrist joint. Then we will do metacarpal squeeze test. It is positive, there is tenderness. Then I will start palpation at the joint line of each metacarpophalangeal joint by rolling my thumbs in the joint line. This is the way of palpation of the metacarpophalangeal joints. Here there is a swelling in all metacarpophalangeal joints, especially this one, the first and the second one, metacarpophalangeal joint. This is a firm swelling of synovial thickening. Then we will palpate the proximal interphalangeal joint, just touching the joints from the side and pressing at the joint line, trying to feel any dewy sensation on these side fingers. Here there is a swelling in this proximal interphalangeal joint. On pressure there is a dewy sensation of some effusion and also synovial thickening. في أي وجع كده؟
لا.
The distal interphalangeal joints are spurred, so in the rheumatoid arthritis, as you see here, there is no tenderness in any of the distal interphalangeal joints. طب في وجع في دي؟ Here there is tenderness and swelling, and the swelling is most likely due to synovial thickening, synovitis, and there is some effusion in these proximal interphalangeal joints. This is the way how to palpate the proximal interphalangeal joints. This is for the distal interphalangeal joints. There was no tenderness here. Also, I will do for the same for the other side. Now there is the inspection and the palpation are finished. Now we came to the movement. So هعمل زي ما أنا هقول لك كده. This is the abduction and the adduction of the fingers. This is the hand grip The patient has very weak, nearly absent hand grip. This is the fine precision pinch. خلي كل صباع مع التاني كده من فضلك. أيوة.
ما اقدرش.
There is marked difficulty in doing the fine precision pinch. The right hand is much more affected than the left. This is the fine precision pinch. امسك صباعيني دول قوي كده. Nearly absent hand grip. امسك قوي كده بالناحية التانية. تمام. absent hand grip. حط ايديك الاتنين كده. This is the dorsiflexion or the extension of the wrist. I will do like this is what we call it prayer position. I will go down to test for the extent of wrist extension. Then I put the back of my fingers, my hands facing each other, and this is the extent of wrist flexion. The patient can't do any of these movements due to severe arthritis in the wrist joint. This is the extension of the wrist joint. This is the flexion of the wrist joint. This is the adduction. This is the abduction. تقدر تعمل كده؟ There is very minimal range of movement in the wrist joint. طب تقدر تعمل الحركة دي؟ This is the prayer position. Lost wrist extension. تقدر تعمل كده؟ ما تقدرش. This is lost wrist extension. طيب ايديك كده. This is lost wrist flexion. The adduction and the abduction movement, he is doing it very minimally. To have a normal movement, I should have a complete, smooth, painless movement. Complete, smooth, painless movement. So the movement, we will do the movement for this patient to assess the function of the examined joint. Here the hand function is nearly 10% of its functions. تقدر تمسك الفلوس دي؟ امسكها كده. This is the fine precision pinch. Difficulty to pick up any coin. بإيدك التانية ممكن. I will do rheumatological examination of the shoulders. Now we will examine the shoulder region. The shoulder region composed of 3 joints. This is with the clavicle articulation with the manubrium sterni. This is the sternoclavicular joint. Moving with the clavicle laterally, it will end in the acromioclavicular joint. The clavicle with the acromion of the scapula making the acromioclavicular joint. This is the sternoclavicular joint. This is the acromioclavicular joint. And this is the glenohumeral joint. This is the ball and socket joint of the shoulder. So, following the rule of inspection palpation movement, we will inspect this region for any swelling, erythema, rash. I will inspect the shoulder bilaterally for any muscle atrophy or winging in the scapula, for any asymmetry, then I will start palpation. Palpation for hotness, compared to the other side. Palpation for any joint tenderness. Inspection, palpation, movement. في أي وجع كده وأنا بفحص بالتك على المفصل ده؟ مفيش. تمام. تمام. في أي وجع هنا؟ تمام. تمام. هنا في وجع؟ تمام. تمام. I will start doing the movement of the shoulder joint or the shoulder region. We will do the collective movement. This is the abduction and the external rotation of the shoulder. We call it the collective movement of the shoulder. And putting both hands in the back. This is the adduction and the internal rotation of the shoulder. Regarding the single movement of the shoulders, this is the flexion of the shoulder, and this is the extension movement, and this is the abduction, and this is the adduction, and this is the circumduction movement like any ball and socket joint. Now I will do rheumatological examination of the elbows. This is demonstration of the normal elbow joint. This is the lateral epicondyle with the thumb, the medial epicondyle with the little finger, and the olecranian process of the ulna. They are doing a straight line relation on full extension of the elbow. On flexion of the elbow, they are making a triangle, the base by the two epicondyles and the apex by the olecranian. Patient elbow, again following the rule of inspection, palpation, movement. افرد ايديك. By inspection, there is flexion contracture of the elbow. This is a common deformity in rheumatoid elbow. There is fullness in the two epicondyles. There is swelling and fullness in the two epicondyles. Also the other side, this is much better than the left side. Here this is the medial epicondyle and this is the lateral epicondyle and this is the olecranian. By inspection, we inspect for any rash, any erythema. Here is the common site of rheumatoid nodule. Also you may find the psoriatic patch here at the elbow. So we inspect the skin for any of this. Then we will start palpation. Palpation for hotness compared to the other side. There is hotness here in the left elbow. Palpation for any tenderness. في أي وجع كده؟ في وجع. Any swelling, any hotness, any tenderness indicates active arthritis. في وجع هنا برضو. There is tenderness bilaterally, but the swelling is much more here in the left side. We will palpate for any rheumatoid nodule. We palpate for any tenderness here also. في أي وجع كده؟ في. This is the medial epicondyle palpating on the bony prominence till the lateral epicondyle. There is tenderness all over the joint line and hotness. All this indicates active arthritis. Then we will do the movement of the elbow joint. افرد ايدك خالص. اتنيها. افرد تاني. Here the patient can't do a complete extension of his elbow. There is angle here. تقدر تفرد كوعك ده كله. تمام. Also here there is failure of extension of the elbow due to fixed flexion contracture, a common deformity in a rheumatoid arthritis patient elbow. So the normal joint movement range, extension, flexion. Then I will put his hand. اقعد كده من فضلك. اقعد. تمام. I will put the elbow in a 90 degree, then doing pronation and supination. Now we will start doing the movement of the elbow joint. This is the extension. The patient can't extend his elbow fully due to fixed flexion contracture, a common deformity in a rheumatoid elbow. The other side, also the same. There is fixed flexion contraction of the elbow. The patient, there is failure of extension of the elbow. اتني كوعك. There is full flexion. اتني الناحية التانية. Here there is marked difficulty in flexing the elbow. So this elbow joint have a fixed limited extension and also limited flexion. It's moving about 10 degrees flexion and extension only. Then I will put his elbow in a 90-degree position to test for the pronation and supination. This is the pronation, and this is the supination of the superior and inferior radioulnar joint. حط ايدك كده، لف كده. This is a pronation, this is supination. The patient can't do complete supination or complete pronation. لف ايدك كده. As you see here, the patient putting his hand in a mid position. ايدك التانية نفس الكلام. Here there is a loss of supination. Also the pronation is not complete. This to test for the superior and inferior radioulnar joint. Now examining the knee region. Again, inspection, palpation, movement, or look, feel, and move. By inspecting the knees, we inspect the skin for any skin rash, erythema, scars. We inspect here the knees. It's a common site for rheumatoid nodule, for any swelling. By inspection, there is swelling in the medial dimple. As you see here, there is ballooning of the medial dimple. Here also, but the left side is more. And this is the lateral dimple. Also, there is fullness in the lateral dimple. And this is the lateral dimple. This is the medial dimple, ballooned. There is some wasting in the muscles of the thigh. Also in inspection, we will try to find any relation between both knees. We may find genovarus deformities in osteoarthritis or a valgus deformity. Here, this is a normal relation between both knees. On palpation, I will palpate for hotness, any hotness. There is bilateral hotness at both knees. Regarding the palpation, for as we told before, it is for hotness and for tenderness and for the swelling. اتني رجلك شوية كده. I will palpate for any tenderness around the joint capsule. Here I am palpating the joint line on the tibial bony prominence. في أي وجع كده؟ There is tenderness all over the knee joint. هنا في وجع؟ and palpate the other side. في أي وجع كده؟ Palpating on the tibial bony prominence and on the knee joint capsule for any tenderness, any hotness, any erythema. All these indicates active arthritis. So there is bilateral tenderness on the hotness and swelling with fullness of the medial dimple bilaterally more on the left side. On palpation of the knee, there are two special tests. The patellar tap test for moderate to marked effusion and the massage test for minimal effusion, to detect minimal effusion. Regarding the patellar tap test, we will feel the patella first. This is the patella. Here I will press the effusion. I will press the suprapatellar pouch and pressing by the index and the middle finger on the patella, trying to feel the ballotment of the patella in marked effusion. The idea of the massage test, here I will do massage of the medial dimple, one directional movement by one directional movement, then squeezing the lateral side, back again, squeezing the lateral side by continuous semicircular movement, and you will see this ballooning of the medial dimple reappear again. Massage test, massaging the medial dimple first. So we will lead this effusion or this fluid to move away, then squeezing the lateral side of the knee and observing for reballooning of the medial dimple. This is a massage test. Now, the movement of the knee joint, it is like flexion and extension. He can't extend his knee fully. Here in the popliteal fossa, I can feel the Baker's cyst, this swelling in the popliteal fossa due to herniation of the synovial membrane of the knee joint. This is a common deformity in aggressive rheumatoid knee, the Baker's cyst swelling in the popliteal fossa. Here, the Baker's cyst in the right side, but here there is no Baker's cyst. I will show you the Baker's cyst. This on inspection of the popliteal fossa from behind, as you see here, this is the swelling of the Baker's cyst. Compared to the other side, this is normal, and this is the swelling of the Baker's cyst, herniation of the synovial fluid of the knee joint. So regarding the movement of the knee, we will do flexion. The patient can't flex his knee except to this level, and extension, also he can't extend his knee fully. There is an angle here. He should do complete extension, complete flexion. While doing the flexion and the extension, I will try now to feel the crepitus by this hand, to feel the crepitus of secondary osteoarthritis of the knee. Also this side. I can feel the crepitus of cartilage damage due to secondary osteoarthritis of the knee. تعرف تتني رجلك كده لوحدك؟ لا، واحدة واحدة من فضلك. افردها تاني. طيب. اتني الرجل دي للآخر، على الآخر، اتنيها على آخر ما تقدر. دي آخر حاجة. طب افردها. تمام. There is limitation in both flexion and extension of the knee, and there is crepitus bilaterally due to secondary osteoarthritis. Thank you. Now I will examine for the ankle and the small joint of the feet. The ankle is a joint between tibia and fibula with the talus bone. The ankle responsible mainly for plantar flexion and dorsiflexion of the foot. The next joint is the subtalar joint, and the subtalar joint is the joint between the talus and the calcaneus. The subtalar joint responsible for an inversion and the eversion of the hind foot. The next joint is the mid-tarsal joint, and the mid-tarsal joint responsible for inversion and eversion of the forefoot. The next joint region is the metatarsophalangeal joint, and this is responsible for the plantar flexion and the dorsiflexion of the toes and the interphalangeal joints of the toes. Now the last region in the rheumatological examination, we will do rheumatological examination of the small joint of the foot and the ankle. First, the ankle joint. This is the ankle joint between the two malleoli, responsible for the plantar flexion and the dorsiflexion of the feet. This is the function of the ankle joint. This is the subtalar joint below the ankle. The subtalar joint, as you see, responsible for inversion and eversion of the hind foot. And this is the mid-tarsal joint between the metatarsals and tarsals, responsible for inversion and eversion of the forefoot. Inversion and eversion of the forefoot. And these are the metatarsophalangeal joints responsible for plantar flexion and dorsiflexion of the toes. And this is the interphalangeal joint of the toes, also plantar flexion and dorsiflexion of the toes. This is the small joint of the foot. So now, following the rule of inspection and palpation and movement, by inspection, there is a hallux valgus deformity here. There is a swelling in the first metatarsophalangeal joint and deviated medially, and the big toe is deviated laterally. This is what we call hallux valgus deformity. Here there is an overriding toes, a common deformity in rheumatoid foot. By inspection, we inspect for the medial arch of the foot. Here is the medial arch of the foot. Here also the medial arch of the foot. There is a huge swelling at the ankle joint of the right side, as you see here. And this swelling is much more than the left side ankle. The skin looks normal, with no rash, no erythema, no scars of previous operations. Here there is a scar of an old wound. So this regarding the inspection. Inspection and palpation and movement. On palpation, I will palpate for any hotness. There is hotness here at the ankle region, indicating active arthritis. Other regions are normal. Then I will palpate the joint for any tenderness. I will start by palpation of the ankle. Palpation of the ankle, palpating at the medial malleolus. في أي وجع كده؟ There is pain on palpating at the medial malleolus. Then moving to the lateral malleolus في وجع كده. Huh? There is tenderness at the lateral malleolus and huge swelling, as you see. This swelling is partially due to active arthritis of the ankle and partially due to pitting edema. Behind or below the medial malleolus, there is pitting edema, and you may find bilateral pitting edema in a rheumatoid arthritis patient. The other side also there is edema, but much more on the right side due to extensive antigen antibody reaction. Long-acting antigen antibody reaction may leads to amyloidosis of the kidney and heavy proteinuria. That's why you may find pitting edema, ankle pitting edema in rheumatoid arthritis patient. So there is a swelling at the ankle, part due to pitting edema and partially due to ankle arthritis. Then now the metatarsal squeeze test. في وجع كده؟ This is the metatarsal squeeze test. There is tenderness and positive metatarsal squeeze test, indicating an inflammation and active arthritis in all metatarsophalangeal joints. Now, there is tenderness all over the ankle. There is positive metatarsal squeeze test. Now, on palpating the metatarsophalangeal joint, في أي وجع كده؟ There is tenderness all over the metatarsophalangeal joint. الناحية دي برضو؟ أنهي أكتر؟ الناحية دي ولا؟ The right side is much more in the pain and tenderness in the right side, and as I told before, the swelling of the ankle and the ankle arthritis is much on this right foot. So there is tenderness on the metatarsophalangeal joints, all the metatarsophalangeal joint. في أي وجع هنا كده؟ And the interphalangeal joints. Don't forget to observe for any erythema, hotness, or swelling in the first metatarsophalangeal joint, as if this is present, it might indicate acute gouty arthritis or podagra. Here, this is the first metatarsophalangeal joint, looks normal, and the skin is not red or erythematous. Now the movement, this is, we are finishing now inspection and palpation of the small joint of the feet and the ankle. And knowing now each joint and the function of each joint, now we'll try to do the movement of the foot and ankle. رجليك لتحت كده. This is the plantar flexion. رجليك لفوق. This is the dorsiflexion. رجليك لجوه الاتنين كده. This is the inversion. The patient can do inversion on the left side beautiful inversion on the left side, but he can't do this inversion on the right side due to active arthritis and stiffness at the ankle joint. رجليك لبره كده. This is the eversion movement. This is an active movement now as the patient doing the movement by himself. Then I will try to do it passively for him. This is the رجليك لفوق كده. This is the plantar flexion. This is the dorsiflexion of the ankle. This is the plantar flexion of the ankle. This is the inversion. This is the eversion of the forefoot. I will catch the heel of the patient. This is the inversion, and this is the inversion. This is the inversion, and this is the eversion of the hind foot. Inversion, eversion of the hind foot. This is the movement of the subtalar joint. Inversion and the eversion of the forefoot. Inversion and the eversion of the forefoot. This is the movement of the mid-tarsal joint. This is the plantar flexion and dorsiflexion of the toes. Plantar flexion and dorsiflexion of the toes. This is the movement of the metatarsophalangeal joints.